Good evening, everyone. My name is Eugene Choi, a member of International Committee of K-MIPS. And today I have a great honor of serving as the moderator for this webinar. On behalf of K-MIPS, it is my pleasure to welcome you all to the first K-MIPS webinar hosted by the Korean Minimally Invasive Pancreatic Surgery Society. Today, under the theme, Building and Expanding Minimally Invasive Pancreatic Surgery, we have a fantastic lineup of speakers and panelists who will share their expertise in this field. So now let's begin with Professor Kang, President of K-MIPS, to deliver the opening remarks. Professor Kang.
Thank you very much. Good evening, my colleagues. Welcome to first K-MIPS Webinar Symposium under the title, Building and Expanding Minimally Invasive Pancreatic Surgery. This time, we prepared very interesting and practical scientific programs for safe and effective minimally invasive pancreatic surgery. Also, we invited important international experts in this field so that every participant can have a great insight from their comments and lecture during this symposium. As a president of K-MIPS, I hope this webinar symposium will provide you the good opportunity to improve your cognitive skills and the future collaboration with K-MIPS as well. Thank you very much.
Thank you, Professor Kang. Now I would like to invite Professor Wooil Kwon, Chair of the International Board of K-MIPS. He works at the Seoul University Hospital, and he'll introduce this first webinar. Professor Kwon.
Thank you for the introduction. President Kang said pretty much everything. But anyway, welcome everyone to K-MIPS Webinar Series number 1. I am Wooil Kwon, and I'm serving as the Director of the International Committee of K-MIPS. This year marked the 5th anniversary of K-MIPS. And during the last 5 years, minimally invasive pancreatic surgeons in Korea have been gathering to advance our skills and knowledge of minimally invasive pancreatectomy. And at the same time, we have engaged ourselves in educating young HPP surgeons, helping them to shorten their learning curves, providing tips and tricks, and also giving advice regarding how to overcome troublesome situations. The K-MIPS steering committees have continuously been seeking ways to provide our members with broader insight into minimally invasive pancreatectomy. As a part of this endeavor, the International Committee, under the guidance of our President Kang, has prepared this webinar series. The theme of this webinar is Building and Expanding Minimally Invasive Pancreatic Surgery. So the first session focuses on how to overcome difficult situations, thus the expanding of the indication of minimally invasive pancreatectomy. The second session focuses on building a robotic program. To deliver world-class information to the members and attendees of this webinar, we invited many world-renowned minimally invasive pancreatic surgeons. So for the first session, I'd like to thank and welcome Dr. Shin-E Wang of Taipei Veterans General Hospital in Taiwan, Dr. Yuichi Nagakawa of Tokyo Medical University in Japan, Dr. Julian Choi of Epworth Hospital, Richmond in Australia, Dr. Brian Kim Po Go of Singapore General Hospital and the National Cancer Center in Singapore, and Dr. Palanisamy Senthunappan of GEM Hospital in India. Together with our former president, Dr. Yoo-Seok Yoon, they will review and treat cases presented by many surgeons and share their experience and expertise with attendees. The second session takes the form of an invited lecture. And for this lecture, I'd like to thank Dr. Jin-hee of Johns Hopkins University in the US, who has readily agreed to share his institutional experience in building a robotic pancreatectomy program. So I hope the attendees find this webinar helpful and informative. And as the series number suggests, the International Committee will continue to organize webinar series number 2, number 3, number 4, and so on, with more attractive and informative programs. My wish is that this webinar series will provide insights and knowledge to not only Korean minimally invasive pancreatic surgeons, but to surgeons worldwide in the future. So thank you, speakers and expert panels, for your participation. But most of all, I'd like to thank the attendees for joining us in this webinar. And with that, I'd like to have this webinar series number 1, Building and Expanding Minimally Invasive Pancreatic Surgery, to begin. Thank you.
Thank you for kind introduction, Professor Kwon. And now we will move into our panel discussion session titled Cultivating Resilience, Reviewing Crises and Experts. This session will be chaired by Professor Yoo-Seok Yoon from Seoul National University Bundang Hospital in Korea and Shin-E Wang from Taipei Veterans General Hospital in Taiwan. The panels include surgeons from across the globe, each with extensive experience in managing complex surgical cases. Please start, Chairman Yoo-Seok Yoon.
Okay. Hello, everyone. I'm very pleased and honored to chair today's panel section for the first K-MIPS webinar. My name is Yoo-Seok Yoon from Korea. My co-chair is Shin-E Wang. Shin-E Wang is online. Could you give some comment?
Okay. Thank you. It's my honor to be here to meet everyone. Sorry, a little bit late, but looking forward to this meeting. Yes.
Okay, thank you. I will start the section. In this section, we will share 4 challenging cases in minimally invasive pancreatectomy, and then have discuss the cases with 4 invited experts. For this section, we have 4 distinguished experts from around the globe as panelists. Before starting the section, I'd like to ask each of these panelists to briefly introduce themselves. This Nakawa. Nakawa is online.
Yeah, nice to see you. Thank you for giving me this opportunity.
Thank you. Dr. Choi from
hello,
Australia.
good evening. I'm Julian Choi from Melbourne, University of Melbourne, Epworth Hospital and Western Health.
Okay, thank you for your time. And Brian Go.
Hi, nice to meet you.
Yeah.
From Singapore.
Yeah, good to see you online. Yeah. And Sentinathan. He's not online. Okay, we will start. There is in this section is 1 hour. There is in 1 hour section we are going to have 40 cases. We are going to have 7 minutes of presentation, and followed by the 8 minutes is a discussion with the panelists and his participants. Let me get started. The first speaker is Jaewoo from Kangbuk Samsung Hospital, Kangbuk Samsung Hospital from Korea. He will present difficult pancreaticojejunostomy. Please, Kwon.
Thank you for introduction. Okay. Can you see the slide? Can I start?
Yes, please.
Okay. Hello, everyone. I'm Kwon. Jaewoo from Kangbuk Samsung Hospital, and I'd like to express my gratitude to the organizers and chairman for giving me this opportunity to present today. I'll be sharing a challenging pancreaticojejunostomy case that I recently encountered and would greatly appreciate the advice and insight of the expert surgeons here. This patient is a 38-year-old male with obesity, having a BMI of 32.4. He was admitted to the hospital presenting with jaundice, and biopsy confirmed the distal bile duct cancer. Considering the patient's financial situation, I plan to perform a laparoscopic pancreaticojejunostomy. The CT scan showed the patient obesity and confirms the presence of the ERBD. The pancreatic duct is not clearly visible on CT and MRI, and its diameter is estimated to be between 1 or 2 millimeters. Here is a video of the pancreaticojejunostomy. During the pancreatic transection, a pancreatic duct measuring approximately 1 millimeter was identified near the lower border of the pancreas. You can see the green point, and you can see the pancreatic duct. First, the pancreatic duct was sutured and anchored at the 12 o'clock position using PDS 5O. To facilitate the anastomosis, the pancreatic duct was dilated by the insert the stent. In this case, I used 4 French and 5 French pediatric feeding tube. Next, the lower border of the pancreas was sutured to the serosal to the jejunum using barbed suture material. Barbed suture is very useful and convenient because its strength of suture material and the tightening for approximation between pancreas and jejunum. A small foramen was then created in the jejunum, and duct to mucosa anastomosis was started. Regardless the duct size, I aim to place sutures in at least 6 directions. First, I start suture at 9 o'clock direction, and then suture 3 o'clock direction. After that, start 6 o'clock direction suture and tie. After insert the internal stent, suturing of 10 o'clock and 12 o'clock is made. Suturing the internal stent with previous anchoring suture. Start tie of each direction. In this case, while tying the 12 o'clock suture, pancreatic duct laceration was identified. The additional suture was placed to reinforce this area. After tying all sutured area, interrupt suture was used to attach the upper border of pancreas to jejunum with Prolen 4O. This patient is not a particularly special case, but represents a common challenging scenario that many MIPS surgeons are likely to encounter. Risk factors for POPF that can be confirmed in this case are as follows: soft and friable pancreas, small size pancreatic duct, and not a pancreatic cancer or chronic pancreatitis. And he's also had other risk factors such as male gender and high BMI. After reviewing this patient case, I would like to ask the following question to the experienced colleagues here. First, would you perform conventional two-layer duct mucosa or modified Blumhardt anastomosis? Second, barbed suture material is proper in this case, or only use monofilament suture. Third, in the case of small pancreatic duct, how many stitches are acceptable? First, what is the proper diameter and length of internal stent? For example, with pancreatic duct diameter or smaller than pancreatic diameter. Fifth, what should I do when I found the pancreatic duct laceration during the suture? Last, In this case of high-risk patient, which method is better, laparoscopic or robotic or open anastomosis? I'd like to seek advice from experienced colleagues regarding the challenges I faced during this case. Thank you.
Thank you for nice presentation. Could you show this question slide?
Okay.
Yeah. I'd like to ask this all question to this panelist, but there's some this panelist doing only robotic surgery, and some this panelist doing laparoscopic surgery. And anyone of these panelists can give this opinion or answer to this Dr. Kwon's question.
Okay, can I start? I'm Senthil Nathan from India.
Hi.
Yes.
Could you give me some comment?
Yeah,
For
yes.
different situation? Yeah.
Yeah, very good videos and nice lecture. I'll give my comments on all the 6 questions quickly. I do modified Blumgott anastomosis. It's a duct to mucosa anastomosis, but we take transpancreatic stitch to have the jejunum clawed onto the pancreas without any tension. So first question is, it's Blumgott modified Blumgott anastomosis, duct to mucosa suture. We still use monofilament suture because the duct mucosa is thin, friable. So we use a 5O PDS monofilament stitches. Bobbed, yes, probably in dilated duct we might use, but in undilated duct, I will not still use it. In the future, I may use it, but as of now, it's 5O 4O PDS. Stitches, we use continuous stitch. Previously, it's about 6 stitches, but now we use continuous stitches. Again, minimum of 6 stitches, even in undilated duct. Internal length is about 8 centimeter to 10 centimeter, 8 centimeter around. And then we keep equal proportion into the pancreatic duct as well as onto the jejunum side, so that it doesn't slip into the jejunum. At the same time, it doesn't get siphoned onto the pancreatic parenchyma completely. The 5th question is pancreatic duct laceration. Yes, we do get pancreatic duct laceration sometimes. To avoid that, we keep a cuff of pancreatic duct length of about 5 millimeter away from the cut margin, so that we can identify the pancreatic duct and then we can able to suture it. So if there is a laceration, we suture, put additional stitches onto the pancreatic parenchyma as well, so that we don't, we can reduce the chance of a leak. Last, the question is about laparoscopic versus robotic versus open. I prefer laparoscopic resection and robotic reconstruction given a choice in high-risk patients. That's option number 1. Option number 2 is complete laparoscopic resection and anastomosis. Choice number 3 is robotic resection and anastomosis. Open in case of borderline resectable tumors, where sometimes we wanted to have the finger or the learned finger onto the pancreas, then we go for open surgery. These are my comments. Once again, congratulations for a beautiful presentation.
Okay, thank you for your valuable comments. There's any other the comments from this panelist? Brian Gold, do you do this laparoscopy anastomosis or robotic anastomosis?
So, like Dr. Senthil, my preference for high risk is laparoscopic resection and robotic anastomosis. But in Singapore, due to resource constraints or costs, we still occasionally have to do laparoscopic anastomosis. And for this case, I would not do a duct to mucosa for laparoscopic. For robotic, I will do a modified Bloom guard with duct to mucosa. But for laparoscopic, I would follow what some of the Chinese surgeons do, where we do a purse string. I think this was developed in Guangzhou, where they put in a stand, anchor it, and then we put in a purse string around the duct. And that is what I would do for such a small duct for laparoscopy rather than duct to mucosa. Because I think for laparoscopy, there is a risk of pancreatic duct laceration compared to robotic surgery.
Okay. Dr. Nakawa, I just know that you do this continuous duct to mucosa anastomosis.
For robot.
Right? Continuous duct to mucosa anastomosis.
Yeah. When I do the robot, so the robot surgery, so I use continuous.
Even for the small size duct.
Yeah. When I use the robot, so the continuous.
What is the advantage of the continuous duct to mucosa? I think that kind of technique can reduce the risk of this duct laceration. Do you think so? Do you have give some tips for this preventing the pancreatic duct laceration like that?
Actually, before starting robotic surgery, I also did many cases of the laparoscopic duct mucosa, everybody knows that the laparoscopic PJ is very challenging. So actually I practice a lot, but still now, so I believe that it's a very difficult operation. But when I start the robotic surgery, so many those suturing that become much easier than before. So even it's not so difficult for me. So actually, recently, young surgeon in my department do the robotic PJ and using continuous suture, but their technique is so nice. So I don't think the some laceration occur. Even the pancreatic duct is small. So if I were Dr. Yoon, Professor Yoon, probably I can do robotic surgery, but my technique is not so good. So
okay, thank you. There's Dr. Julian Choi.
Yeah, look,
do you have any opinion?
Yes, look, I think at the end of the day, I think really it's your preference, isn't it? Whether it's a duct mucosa or Bloom guard, when you anticipate really difficult anastomosis, I mean, this patient's almost likely to have an 8 times more chance of leak than your wide, hard pancreas with dilated pancreatic duct with a pancreatic cancer. So the risk of leak is inherently high. And when we all been there where you put the sutures through the duct and duct tears, your heart sinks and know what to do. And unfortunately, not many cases I've had to experience this, but I have occasionally gone back to dunking in a situation like this, and end-to-side pancreaticojejunostomy. And also, if the posterior and anterior sutures also cut out, not only the ductal sutures, I actually consider total pancreatectomy because I know that this patient's going to have a really stormy course.
Okay, thank you. Shin-E Wang, do you have any comment for this situation? Small size duct.
Yeah,
for us,
we've never we've been changed our technique to modify Bloom gut PJ. I think since 2012. So we've been doing that over 10 years. No matter what types of pancreas remnant we have. So with this fragile and very small pancreatic duct, I think the tissue handling is very important. So I want to jump to this number 6 question. I would rather do robot anastomosis than laparoscopic. And if I think I only am able to do laparoscopic approach for this case, then I would consider open anastomosis if I think the leakage rate is definitely very high for this patient. It really depends on how you're comfortable or how proficient you are with the laparoscopic anastomosis of PJ. So if you are worried and you don't have robot, then I think the hybrid approach for open anastomosis is the key. And we never use barbed sutures. We only use monofilament. And for smaller duct, usually at least maybe 6 stitches. And then if the duct is more dilated, then we add more. For the stent, we usually use maybe 6 French or 8 French, sometimes 5 French stent. And in case of pancreatic duct laceration, like when we do transection, we always want to have a little bit length of the pancreatic duct longer than the stump, if it's possible. And unfortunately, if you have a duct laceration and it's severe, then sometimes you may need to consider redo or take down all of the ductal mucosa and maybe have another cut end and properly do the suture again. That's my opinion.
Okay, thank you for your comment. Okay, thank you, Professor Kwon. We are going to move to second presentation. Second speaker is Hee-Jun Kim from Chonnam National University Hospital, Korea. He will present on expected bleeding. Professor Kim, please.
Can you see my slide?
Yes, you can start.
Good evening, everyone. I am Hee-Jun Kim from Chonnam National University Hospital. It's a pleasure to be here with you today. My hospital is located in Gwangju City in the southwestern region of Korea. As a local hospital, we manage a relatively smaller number of cases compared to major centers in Seoul. I began performing laparoscopic pancreaticojejunostomy in 2015 and have completed approximately 150 cases to date. Despite having performed over 150 cases, there are still many challenging aspects. In particular, intraoperative bleeding not only prolongs surgery time, but also significantly increases the surgeon's mental and physical stress. Today, I look forward to discussing and solving the bleeding-related challenges with the esteemed expert here. The first video demonstrates venous bleeding. Bleeding from small venous branches is a major cause of prolonged operative time and impaired surgical vision. Initially, I believed the ligation was secured with clips. However, bleeding occurred during retraction. Similarly, despite applying a clip to the IPDV, bleeding occurred at the clit site. It is unclear whether this resulted from clipping technique or traction. This is a similar case. Furthermore, bleeding occurred even during simple blunt dissection. In this case, we carefully reviewed the splenic vein and IMV on the preoperative CT, but bleeding arose from an unexpected location. Next is arterial bleeding. Arterial bleeding is a far more serious situation. During lymph node dissection along the common hepatic artery toward the celiac axis, arterial bleeding occurred. At that moment, the assistant left hand was retracting the hepatic artery, while the right hand was securing the surgical field by pressing on the pancreas, leaving no opportunity for further assistance. I managed to suture the bleeding focus with difficulty. However, due to being in a state of panic, the tie was not performed perfectly. And as the bleeding stopped through suturing, hematoma was noted on the arterial wall. Fortunately, no complication occurred post-operatively, but I could not sleep well until the patient was safely discharged. The next case involves an arterial fracture. Frankly speaking, I could not realize to the term fracture of artery until I experienced. During a distal pancreatectomy, when the splenic artery was identified and clipped, fracture occurred, resulting in massive bleeding. In this situation, both ends of the assistant were unavailable. I had to hold the bleeding stump with one hand, leaving me unsure of how to control the bleeding with my only one hand. I attempt suturing with one hand. The first try of the suturing. was not successful. Fortunately, the bleeding was eventually controlled. However, it was a terrible 30 minutes I hope never to encounter again. These are my questions. Please tell me your opinions and experiences. Tips to avoid venous bleeding, arterial bleeding, complication prevention, arterial fracture, how to prevent or predict. Thank you for your kind attention. Chairman, your mic is off.
Okay. Thank you, Professor Kim, for valuable these cases. I'd like to ask his panelists to give some advice to Professor Kim's.
So can I start?
Yes.
Yeah. So once again, excellent videos, very important, pertinent videos, good teaching videos for all of us to learn how to avoid bleeding, and in case if there is a bleeding, how to manage. You have shown excellent character, a lion's heart in managing these complications. Those of you who have been into this situation would really experience the heart in our mouth type of feeling, how to bail out, whether to convert it or to manage it. So my first thing is prevention. The next one is proper management. Sometimes we might need to convert, but again, conversion here is also a rapid conversion. So we should stabilize the patient, have a control, and then convert it. I'll come to the, prevention. Venous bleeding happens because of traction injury. And I totally agree. I will be very careful in dealing with the Henle's loop of vessels, the colic and the pancreatic branches joining, making a common trunk and then joining the superior mesenteric vein. That's the very common area. When we try to retract the colon, when we try to do the uncinate dissection, or when we try to do the neck of pancreas dissection, this vein is commonly injured, which is directly draining into the superior mesenteric vein. So high flow, low pressure veins. So these are very notorious to control. Traction has to be proper, no undue traction as far as venous bleedings are concerned. And as far as possible, avoid energy sources in those veins which are thin-walled veins. Always use clips or ligature to tie and secure the vessels. This is for the venous bleeding. Arterial bleeding, generally, I would say it's torrential, but it's controllable easily because we have vessels where we can catch it. Damage to the vessel is less. And more importantly, when we go on the surface of the vessel, it is like on the adventitia, that's the most avascular plane. So don't afraid of going on the surface of the vessel. A subadventitial dissection is not needed. But what is important is on the vessel, surface of the vessel, we go, identify it, have a proximal control, and then work our way either from the common hepatic towards the hepatic artery proper, or celiac axis towards the splenic artery, so that we have always a proximal control along with the working on the vessel, not away or not too close. Arterial fracture that happens whenever there is an undue traction on the arteries. So especially if it is associated with a lot of calcium deposition on the intimal tear and the fracture happens. Even on the ligature, sometimes we feel afraid whether that will open up. So be very careful with regards to the old patients whom we have a lot of calcium in intimal deposits. Plaques will be there. So we have to be very careful in handling those old age arteries. So these are my tips in avoiding. And finally, prevention, yes. Proximal controls, obtain proximal control, then have a suture in place, suture it with the assistant sucking the blood, keeping the area filled, and more importantly, have a lion's heart in dealing with such adverse situations. In the interest of patient safety, whichever is possible, plan an elective conversion after having secured the proximal control, or if you can manage by yourself without the need to convert. It all depends on one's caliber, one's experience. But ultimately, let's not forget patient safety is of paramount importance. Thank you very much.
Thank you for your valuable comment. Is there any comment from panelists? No. I have just one comment. Oh, okay. Please go ahead.
Okay, so I think my comment would be, I agree that venous bleeding is usually due to traction. I think the first tip is to disconnect the tributary once it's bleeding, because if you leave it attached and try to control the bleeding, the laceration will increase in size. The other thing is, I commonly would use a laparoscopic bulldog. So I don't really like to suture while it's actively bleeding. So if possible, you should try to stop the bleeding with the curved laparoscopic bulldog, which can give you space to suture after it. Or sometimes if there's no space, you can just put metal clips temporarily and then suture on it. So for example, the video he showed where one hand was holding the artery and the other hand was suturing, he could actually just replace the hand with a laparoscopic bulldog, and then he would have two hands to suture. The last comment I would like to add is for arterial fracture, I think we can take tips from liver transplant. So before we ligate the artery in liver transplant, we commonly would actually clamp it first to decrease the pulsatile and bounding pressure in the artery. And I think that will help to decrease the chance of fracture after putting a clamp and then only clipping and ligating it. So those are my comments for this part of the lecture.
Okay, thank you. Due to time limitation, we have to move to certain cases. Professor Shin-E Wang will moderate the last two cases.
Okay, so actually I wanted to comment a little bit on the venous bleeding, but anyway, because of the time, if we have time, I'll give some comment about the second speaker's venous bleeding. So we move on to the case number 3. We have Dr. Shin Yeung from Princess Alexandra Hospital, Australia, showing how can I secure the best view when operating a super obese patient.
Thank you very much for the kind invitation. And I don't have any specific case to show, so I want to show a couple of our patients, our series, because, in our country, we have quite a lot of obese patients. So let me just get my presentation. Okay. You can see that now, yeah?
Yes, you can start.
All right. So, as you can see, in Australia, if we look at obese patients, almost a third of our population is considered obese, compared to Korea, which is only about 8%. And if you look at patients who are overweight and obese, you can see that almost 2/3 of our patients or our population is overweight and obese. So this reflects in our patient population. So just to give you a bit of background in our local situation. So Australia is a small country in terms of population. We have 27 million people. It's a very big geographic country, so the patients are spread out through a very big distance. So where I work in Brisbane, which is the capital of Queensland, on average we would do about 60, just over 60 Whipples a year. And I want to concentrate on Whipple procedure because I think this is the most technically challenging and high risk operation when we talk about minimally invasive pancreatectomy. So in my place, which is Brisbane Metro South, we have two surgeons, myself and my colleague, Dr. Sarah Wardener. We started off our minimally invasive and robotic pancreas program across 3 hospitals. So we first started our robot pancreas program more than 10 years ago now. We started our first Whipple in about 2017, and more recently we've been able to expand our program to the government hospital, the public hospital, and by the end, currently we have over 100 robotic pancreaticojejunostomies in our series. So it's a small number compared to big international places, but it's a big number for our local population. So when we selected our patients, we selected any patients with any pathology that was away from vessels while we were starting. But in terms of their BMI, we selected patients up to 40, but preferably up to 30 BMI. Females are generally better than male patients because their fat distribution is more external, but that's not always the case. And I'll show you some video later of some very large BMI women, which were almost like operating on men. We recently published our early series of our results. And just to show you some of our numbers here, this is our earlier series to last year. We published 72 patients, and if you look at our average BMI, it was about just under 27, but we had some quite large patients. And if we look at the graph here, about almost two-thirds of our patients were overweight or obese. Almost a quarter were considered obese. You can see here that actually, interestingly, it only very slightly impacted on our operating time. I mean, our operating times were longish because we were, I guess, still in our learning curves to some degree, but being overweight or obese didn't impact too much on the operating time. And that may be for a couple of reasons. Our results were very favorable compared to internationally accepted benchmarks, except for the operating time. So what did we do about our obese patients? Well, I think my thinking is that when we have these big patients, even before you take them to the operating theatre, you're thinking of how to optimize them before you even do their operation. So we're talking about VLED or VLCD diets and prehabilitation. So what does that mean? For us, when I see the patient, their BMI is over 30, I tell them, well, okay, you need to go on a low-calorie diet with about 800 calories per day. That's about 3,500 kilojoules per day, and limiting but still needing 60 to 80 grams of protein so they don't get protein malnutrition. So we put them all on OptiFast, which is a well-known weight loss shake, which limits them to about 800 calories per day, and making sure that they don't get protein malnutrition. So there's a group of surgeons from our city that reported recently on nutritionist-led very low-calorie diet clinics to help with very obese patients prior to non-bariatric surgery. And I mentioned here in brackets the GLP-1 agonists such as Ozempic or Wegovy. I haven't used those. I would probably be a little bit nervous about that because of the increased risk of gastroparesis and pancreatitis. So we haven't done that, but I put that up there maybe just for discussion later. And the other aspect of preoperative preparation of these obese patients is prehabilitation. So it's not only just their nutrition, but we also get them to exercise and get fit so that they don't get that protein and malnutrition and that loss of muscle mass. So when we get them to the operating theatre, and we sort of aim, I sort of aim for a 5 to 10% excess body weight loss before I get them to the operating theatre, and that helps reduce a lot of the hepatic steatosis as well as the intra-abdominal obesity. But when we get to the operating theatre, there are other sort of tips and tricks that we've used, which includes obviously patient positioning. So this patient was robot Whipple, BMI was just over 36. And we put them on this bed, we strap them to the table, we use foot plates to stop them from rolling off, and we tilt them reverse Trendelenburg almost up to 20 degrees to use gravity to help move all that colon and viscera out of the way. For a normal size patient, and again, our technique has been based on that where I learnt in Pittsburgh. So we use the University of Pittsburgh technique where we have 2 assist ports and the robot ports. So for a thin patient, the line is around about the umbilicus, but in an obese patient, everything is shifted forwards. Shifted superiorly. So the robot ports are higher, so it's closer to the target, and the assist ports are moved up a little bit as well. So I know there are some colleagues of mine that will still put their ports down low, but I found in our experience that if we put the ports very low, the assistant was often skimming over, a lot of fatty colon and the omentum, and had a lot of difficulty getting up to the target area. So we sort of recommended just shifting everything further superiorly with these obese patients. The other thing that's been really good for us is use of this retractor called the Mediflex. It is good because it means that we can put the retractor inside the patient. Everything is out of the way. It keeps out of the way the robot arms. And this, again, is something I learned in Pittsburgh, and it was very, very useful for us for the really obese patients. So this is just a short video showing the Mediflex retractor. If you're not familiar with it, it's basically like this snake retractor, which you are probably all familiar with laparoscopic liver surgery. But it allows us to fix the retraction to the bed and hold the liver up. This patient wasn't very fatty. I just put it up for example. But this patient here had a BMI of 36, 37. You can see the liver is very steatotic. Everything is heavy. Everything falls down. And when you have the patient very head up in reverse Trendelenburg, all of this stuff tends to fall in the way. Whereas having this retractor means that we can hold the liver out the way, get good view of the porta hepatis, and have the third arm of the robot doing other things. This is a patient with a BMI of 41 who I was doing a distal pancreatectomy, Kimura distal pancreatectomy on. You can see that you can't even see the pancreas. It's all covered in fat, but using this Mediflex retractor, we could sort of push everything out the way. And the other trick that sometimes one can use also is suture retraction, not just to suture the stomach up for distal pancreatectomy, but you can also use that same suture technique to suture the fat of the omentum to pull it out of the way. If gravity isn't enough, sometimes in these really fat people, they're quite deep, and despite having them very steeply reverse Trendelenburg, the fat often still falls into your operative field. So the trick that we've sometimes used is to suture this fat and pull it out of the way so that you can get to the distal pancreas. So that's my presentation, just on some of the tips and tricks that we've used to operate on these really obese patients. Thank you.
Okay. Thank you, Dr. Young, for your wonderful presentation. I think you already gave us a lot of tips about how to secure the base view when operating on a super obese patient. So any panelists would like to add on other tips, maybe, perhaps?
I think it's an excellent talk, Shin, and I think it's interesting you raised the question about Ozempic and Wegovy, and I think I do share the same concern with you. I think for other cases, I think they are very useful for a hernia surgery, ventral hernia, and weight loss. I think Wegovy would be excellent. But for pancreatic surgery, I've encountered unexpected pancreatitis in these patients, and also, significant gastroparesis prior to surgery and stomach full of food. So I think there is certainly reason for caution. And now I think we are having some recommendation in terms of when to stop these prior to surgery, and some say 2 weeks, and some recommending it to up to even 4 weeks. So something to consider. It's becoming very common in Australia.
Anybody would like to share about obese patients on robotic or maybe minimally invasive pancreatic duodenotomy? Any?
So I'll have.
May I have
Yeah.
questions? Thank you very much. So thank you. I really enjoyed your talks. But one of the issues, hurdles in the minimally invasive Whipple procedure in obese patient, when we perform the dissection, the SMA lateral border, in obese patient, there are huge omentum may hide the operation field. How could you manage this kind of situation in performing the robotic Whipple procedure in obese patient?
Yeah, so that's a very good question. So what I learned when I went to Pittsburgh with Herb Zay was that the problem is with a very heavy omentum and the colon dropping in the way. What he used to recommend, and what we did when I first came back, he recommended a very thorough mobilization of the right colon beyond the appendix, so that and when you have the patient very steeply reversed Trendelenburg and rolled right side up, the weight of the omentum and colon would pull everything down to the left iliac fossa to retract everything out of the way. But yes, sometimes in the really obese patients, you do then have to rely on your assistant, which fortunately has like 2 hands to help you to sometimes retract and pull everything down. But the trick I learned from overseas was that if you do that more extended mobilization of the right colon and get it all the way past the appendix to the terminal ileum, the weight of it will actually retract it down to the left iliac fossa to keep it out the way, so that when you come up the SMA border, it's almost a straight line. The colon has moved out of the way, but it does involve a lot more dissection of the colon, and that's a trick that we've done as well.
So it's like almost like a cattle brush maneuver, where you take down the right side of the colon, and then you have the gravity to help you, so that a lot of the mesocolon can be moved out of the way. I think gravity definitely helps a lot in obese patients. So during the setup period of the time, you need to really. What I do is we use laparoscopic inspection and to check, and then we adjust the table really to a very reverse Trendelenburg position, and taking down the right side of the colon is very important tip, I think. And you've shown suturing the stomach. I tend to use some kind of like 5 French or 6 French nasal gas strip to wrap the stomach and then suture, because I don't like to suture the stomach wall itself. I'm afraid of tearing. So I think there's another tip. The most important thing is try to expose everything, try to move out of the fat, and do a really meticulous dissection. And then within the fatty tissue, you have to be patient. Eventually seek out all the important vessels and veins for dissection, I think. Okay, if there's no more questions and comments, thank you, Dr. Yeung, for your presentation. And I'd like to move on to the case number 4 for Dr. Yang from CHA Medical Center, Korea. showing high-level bile duct resection and difficult hepaticojejunostomy.
Okay, thanks. Can you hear me?
Yes.
Yes, we can hear.
And can you see my slide?
Yes, we can. Please start.
Okay. Hello, everyone. I am Yang, working for Bundang Medical Center, Korea. My talk is about high-level bile duct resection and difficult hepaticojejunostomy. First of all, can you hear me? I can hear my voice.
We can hear you very well.
Okay, thanks. When do you feel difficult during hepaticojejunostomy? In my experience, when the hepatic duct tissue is too fragile to hold the suture material, and there are multiple small bile duct opening, and tension between lurim and hepatic duct can make hepaticojejunostomy difficult. I'm afraid I have no experiences with small multiple bile duct during MISPD because I highly select the cases. So this time I'll talk about the tension between hepatic duct and lurim. The patient was 44 years male and with digital cancer, and the BMI is not so high, but he got fever due to cholangitis just a week before surgery. So he admitted and got ERCP just 4 days before operation. The fever and laboratory findings was stabilized, so I proceeded this scheduled surgery. This is a CT scan. There is tumor in duct and the distal CBD. Here. So let's see my case. At first, peaceful field, but I felt some distance from umbilicus to hilum, and the liver is totally in leakages, and there is bulky adhesion around hepatic pressure colon and liver, and there is even some pancreatitis in pancreas head due to recent ERCP, maybe. And now you can see the short T colon mesentery and inflammation around mesenteric window. I think these 6 factors can give tension to jejunal mesentery from its root to hepatic duct. So I should have prepared for that. But at that time, I didn't catch the problem. So if I recognize the problem, I should resect here, but I just resected here. After resection, I felt the mesentery quite short. Now digester is beginning. It was hard to just pass the mesentery window. Even this time, I should have resected more jejunum, but I didn't. So due to mesentery recession, necessary tension, ruling cannot be pulled up enough, even for pancreaticojejunostomy. Anyway, I finished pancreaticojejunostomy, and now I have to hepaticojejunostomy. But the hepatic duct is too high. So there was too high tension between jejunum and duct. I made some serious injury. And I realized something went wrong. But I have no choice. I already finished the pancreaticojejunostomy. I usually use 4-0 valved suture anteriorly and posteriorly. The bowel and duct cannot be approximated at once. So I pulled, but there is a pull-through injury. So I cut the liver fixation to gain any tension relief, but it was not so helpful. And sutured as parachute technique carefully. Actually, this patient was my acquaintance, so I felt so sorry. I would cry. When I think the hepatic duct is too fragile, then I use this neobill to reinforce the suture line. I usually use a silicone tube and picks this not to migrate into liver. Can you see here is some gap and in the posterior edge. Luckily, I finished the hepaticojejunostomy and I added another reinforced suture. The suture was done. So I learned from this case, these 6 factors can make tension between lurim and the hepatic duct. And I think the solution, at first I should sacrifice extra proximal jejunum. So if mesenteric tension was expected, I will choose more distal jejunal resection. Or second solution is using retromesenteric lurim route. For open or laparoscopy, I usually use transmesenteric retrocollic lurim, but robotic or some cases I use lateral mesenteric opening, which already created during Coca maneuver. I think this route can give tension-free hepaticojejunostomy. I've never felt tension between hepatic duct and jejunum during this lateral mesenteric luring. So the patient was discharged at the post-operative day 13 without no biliary complication. This was post-operative day 6 weeks CT. There are minor PJ leak. Until now, no biliary complication. Thanks. My talk is ended.
Thank you for your case sharing. Is there any questions or maybe comment from the floor? Okay, thank you. Professor Nagakawa, please.
And thank you very much for showing us a very challenging case. And your suturing technique is so nice. So,
thanks.
But yeah, it's nice. And but if the jejunum is does not reach its bile duct, so I usually sacrifice jejunum to find the appropriate position to reduce the tension. So probably in this case, so did you why don't you resect the additional resection to find appropriate position?
Thanks for your comment, and I am actually your fan. I saw your video many times, and I should resect more jejunum before to determine whether I should resect the jejunum. I should check the distance, but this case I didn't. So it was my mistake. Actually, this patient was my acquaintance, so I want to preserve more jejunum to maintain longer nutritional absorption capacity, but it was my mistake.
And other things, so I also, in this case, I also try to open the mesocolon to pull the jejunum up more. So the problem, this patient is obese patient. So, but I understand. I believe that it's a little difficult to create wide opening open the mesocolon. But so probably if you find a big area, and if you open the mesocolon, probably you can pull the jejunum without tension, I guess.
Thanks.
Okay, we have a question from the audience. They want to know, when do you remove stents placed in the bile duct?
I don't remove the stent.
Oh, okay.
I cannot.
Okay.
I cannot.
I think I also agree with Professor Nakakawa's comment. And I think before you do any reconstruction, you need to anticipate the PJ and the HJ, the tension. You have to anticipate it first before you start any reconstruction, because you started the PJ, and then when you realize that the HJ was a problem, you got stuck because you don't want to take down the PJ and redo everything. So for my maybe my suggestion, whenever we started the reconstruction, first of all, you have to anticipate the tension of the jejunum link that you brought up. And mesocolon approach is almost always our routine. The other one, the original duodenal tunnel, I think we would only consider in maybe low malignancy patients. We never considered in cancer patients because sometimes you get local recurrence around that area, and then that part of the jejunum may be invaded during local recurrence, and you may have a A-loop syndrome, some kind of A-loop syndrome, blowout of the PJ. And I think you need to really, if it's necessary, you need to sacrifice some of the mesenteric vessels so you can have a longer jejunum, and also maybe enlarge the mesocolon window a bit more, so you can bring up more of the jejunum ball. That's my comment to you. Yeah.
Thanks for your comment.
Any more comment from the panelists, or anyone want to discuss about this issue? If not, I think because the time, I think we can close the session about the all 4 cases discussion. Thank you very much for sharing your valuable cases for us to learn. And I think I can move on my role, passing to Professor Kwon, maybe?
No, actually, I'll take the over.
Okay, thank you.
Yes. Yeah, thank you very much. Thank you to all the speakers and panelists for this session. And before we start the next session, we'll take an online photo right now. So everyone, please turn on your camera right now, please. But I don't know who's gonna take a picture. Should I take it?
Yeah, we gonna so the meeting with the secretariat will take the video. I mean the photo.
Okay. Please count on it, please, secretary.
Yes. So once again, please every participant, please turn on your video to take our memorable video. I mean pictures. And while we taking the picture, please make your big smile. Yeah, hand shaking also fine. Okay. Right. Please wait. Okay, so I took enough photo.
Okay, thank you very much. So with the time limits, we'll start the next session. This is the invited lecture section, chaired by Professor Jaewoo Kwon, chair of the academic committee. He works at the Kangbuk Samsung Hospital in Korea. Please, Dr. Kwon.
Thank you for a nice introduction. I'm Jaewoo Kwon, Kangbuk Samsung Hospital, and chair for academic committee of K-MIPS. It's my great honor to introduce Professor Shin-E. He's the chief of the division of HEP and GI surgical oncology at Johns Hopkins University, and a world-renowned expert in surgical oncology and minimally invasive pancreatic surgery. In this session, Professor He will share his insights on building a robotic pancreas surgery program. Professor He, please.
Good morning. Well, good evening to you. This is early morning in the United States. Thank you for the opportunity to join this webinar. Can you see the full screen?
Yes, we can see.
Okay. Well, in the next 20 minutes, I was tasked to talk about, my experience of building robotic pancreas program at Johns Hopkins. I was listening to this webinar in the last 15 minutes. I'm glad to see so many colleagues, friends from Korea, Japan, China, Singapore, India, all over the Asian country to join this webinar. So it's a big event. First, congratulations for hosting this webinar. I'm so happy to join. So building up the program, you have to be in a good team. These are the four surgeons I consider them as my mentors, teachers, friends. You know, I learned everything about pancreas surgery from many people. But these 4 surgeons who taught me everything about pancreas surgery at Johns Hopkins in the last 20 years. John Cameron is still working at Hopkins, although he's not operating. Rich Schulich is now the dean, the director of Cancer Center, chair of surgery at Colorado. Tim Pollack is the chair of surgery at Ohio State. And Chris Wolfgang is now the vice chair at NYU. I learned tremendously about pancreas surgery, although it's all open pancreas surgery from these 4, you know, great surgeons in the last 20 years. So you have to be trained in a good place. We're doing surgery right now. I think it's truly standing on the shoulders of giants. The Hopkins program was established by John Cameron. In his career, he has performed more than 2,400 open Whipples. So starting a robotic pancreas program, it will be the best to start in a high volume practice, because it's really critical, you know, with senior surgeon support, you can select relatively straightforward case for your robotic Whipple in the beginning. Now, the hospital also need to have a vision to support this approach. Luckily, when I joined the group as a faculty in 2015, you know, the hospital has invested tremendously in the robotic platform. In 2015, we had our first Da Vinci Xi, and it was a perfect timing. Like when I started my, you know, personal robotic pancreas surgery, and I was able to use Xi for my first case. And since 2015 now, you know, I've been using Xi doing all my HPV surgery for 9 years, and I've become extremely comfortable with this system. And, you know, with 1 Xi in 2015, now we have 19 Xi in 2024. You can imagine how much, you know, effort the hospital has put in to grow the robotic surgery volume. And they also need to build up the team. Before I started working on the robotic pancreas surgery, I was doing everything laparoscopically. Because the system in America, it's impossible to maintain a stable team. It's very challenging to teach your residents fellows if they rotate on your service every 4 weeks. It's impossible. But by switching to the robot, I was able to train a bedside physician assistant, and she and I have been working together, you know, since 2015. So imagine a stable team is the key factor for everything to go smooth. And you and your team need to grow together in the OR and working on the robot. The teamwork cannot be, you know, emphasized enough for successful robotic program. Now, on the other side, you have to understand, why do we need to switch open to robot? Is it simply because the incision is smaller? Or are we going to achieve similar oncologic outcome? So when Mike Kendrick visited Johns Hopkins in 2011, and he showed us this paper, which again, I was extremely impressed that for the first time, Dr. Kendrick was able to show a different surgical approach was associated with better progression-free survival for patients with pancreatic cancer. Now, his rationale was, you know, patient who underwent laparoscopic Whipple, they have better recovery, had more chance to finish the adjuvant chemotherapy, and probably can even started chemotherapy earlier to avoid a delay. So he associated the laparoscopic approach with better oncologic outcome due to all those benefits. So when we start doing robotic Whipple for patients with pancreatic cancer, we follow the same rule that we believe if we can reduce the complication using a robotic approach, we may help those patients who had the diagnosis of pancreatic cancer who need a multidisciplinary treatment. In the meantime, in the last 10 years, a robotic Whipple has been adopted into many surgeons' practice. You can see the data from NCDB is mainly for patients with cancer. You can also see the data from American College of Surgeons. So over the years, the robotic approach, the adoption has getting popular. And also numerous retrospective studies have showed the benefit of the robotic approach. And so this convinced myself and my team to keep working on this, robotic pancreas surgery. Now, in the last couple of years, especially this year, two major papers were published. Looking at these two publications, thinking about what I've done in the last 10 years, I feel like I'm on the right track. Again, two RCTs confirmed the robotic approach is safe and is associated with short-term post-operative benefit. This paper, from China, this is a randomized clinical trial showing robotic Whipple versus open Whipple, especially for patients with pancreatic cancer and periamputary cancer. So I'm confident more and more papers are on the way to demonstrate similar things, especially the multi-institutional study from Europe, Diploma 2, I think will be published very soon. So this is Diploma 2 study. Again, this was recently presented at IHPBA, and everyone's talking about it. So now we have papers coming from Europe, papers coming from China. I don't anticipate any randomized clinical study will coming from the US. I think in the United States, the robotic approach has been going on for so long. RCT probably is right now unnecessary it's all sometimes impossible to randomize patient into robot versus open approach in the United States. So this is how I do this during my operating room in the last 10 years. So we typically have dual consoles for myself and my trainees sit down at the console. And my physician assistant is sitting at the table side. She's responsible for instrument exchange, firing staplers, doing suction. So we typically use four trocars, four robotic trocars and one assisting trocar. And the assisting trocar will be enlarged when we finish the surgery to retrieve the specimen. Everything is done with robotic instrument, and all the anastomosis was finished intracorporeally. So this meets the definition of a pure robotic pancreas surgery per the recent Brescia consensus. Robotic approach has many intuitive benefit. I'm sure whoever work on the robot can appreciate all this benefit, especially the ergonomic setup, which again, I think in my mind can probably extend the surgeon's career. If you are ready to retire in age 65 in the past, probably you can extend your career probably into 75 or 85. Because again, it makes you comfortable sitting there doing complex surgeries. And you can use ICG to demonstrate the biliary anatomy, which again is critical for a lot of cases. Knowing where the bile duct is can avoid unnecessary bile duct injury. And I had one patient many years ago with this aberrant right posterior hepatic duct. I missed it, and the patient had a bile leak after surgery. And after that, every case I do, I gave the patient ICG to make sure I know where the bile duct and make sure I don't miss any aberrant bile duct. This is very easy to use. And whenever I do a Whipple, I make sure I follow the oncological outcome, because in the beginning, many open surgeons, they always thought that, doing a minimal invasive Whipple, you try to cut the corner, you're not going to achieve the same outcome as I do open Whipple. So whenever I select a patient for a robotic approach, I first ask myself, is this going to display, a surgery outcome that as good as my open approach? If the answer is yes, I do it on the robot, right? So for example, if right now, 10 years into this robotic, business, I'm still not comfortable to do a graft reconstruction after resecting the portal vein. Because in my mind, this kind of case, I would do better and quicker with an open approach. So I'm not going to do that kind of cases on the robot. But who knows, in a couple of years, if I get more and more comfortable, more and more experience, I may be doing that. So again, this is the example to say, if you do robotic approach, you have to follow the same oncological principle as you do for the open surgery. If I do it for a Whipple, I need to follow the principle to make sure I do a triangle dissection and achieve, all the exposure and display of those important vessels. So this is a quick example here. So this is a patient, I've showed this video many years ago. She's young, she's healthy, she had many chemotherapy, 6 months chemotherapy before the surgery. The tumor had good response, but it's still sitting very, very close to the SMA. But there's no vessel occlusion, so this would be a really good approach for the robot, especially for the obese patient. You can tell, like most patients in America, they're not like Asian patients, but with the careful dissection, you can expose all those structures. I use harmonic for the majority of the cases. Now, occasionally, for extremely obese patients, I use a combination of harmonic and vessel sealer. Harmonic instrument is not long enough for big patient in the United States. Sometimes I've used a combination of both. But for routine cases, I almost only use harmonic. So this is dissecting the vein away from the encinate. And after that, you're going to see the exposure of the normal SMA first. Once you expose the SMA, with this 20 times magnification, you can see the difference. Really can let you identify where the true dissection plane outside of a normal SMA. So let's see if we can move the video a little bit. So once you're getting to the so-called level 3 dissection, and you can just use a harmonic to keep following the wall of the SMA. And all the small branches coming from SMA can be easily identified and suture ligate and control. For example, when you go along the SMA, you probably see at least 1 or 2, sometimes 3 branches coming from the right side. All those can be easily, controlled. And if you do need control the root of the SMA, it's also easily achievable by dissecting along the left side. In this case, I don't need to control the root, but in some cases you have to control the root of the SMA with the bulldog before you can engage this kind of fine dissection. So this is controlling a small branch coming from the right side of SMA. There's no room to put on any clips. It just suture ligate with the 5-0 proline stitch. And as I said, in the end, you want to achieve the so-called triangle dissection, and make sure you get all the, pancreatic nerve, neurotic, lymphatic tissue away from SMA. And I'm trying to avoid, whenever possible, I'm trying to avoid a 360-degree dissection, because those patients, the post-op recovery and diarrhea is always an issue. I know that we probably can manage those patients with anti-diarrhea medication, but their quality of life is just not ideal. So this is the end of dissection. You achieve the triangle exposure and remove the lymph nodes just above the left renal vein and IVC, the so-called 16A. Patient recover well. Obviously, that's the goal of any surgery. Now, in the last several years, you can imagine that with more and more experience of robotic pancreas surgery, I'm doing more the so-called parenchyma preserving surgery than before. In the old days, I remember the first year, my robotic Whipple, like half of those cases are for benign and low malignant disease, such as neuroendocrine tumor and IPMN. So the reason for that was very simple, because I was, in the beginning, I was still in the learning curve. And 10 years into those cases, in hindsight, if I do it now, I'm not going to do the so-called straightforward, easy robotic Whipple anymore, because all those cases, IPMN, neuroendocrine tumor, span tumor, I'm just taking this so-called parenchyma preserving approach. So this is a young patient, he's in his 30s with a big IPMN, a chronic pancreatitis. He was offered a Whipple at outside hospital and came to me, and so we did this duodenum preserving head resection. Now, the only reason I can do this in the last couple of years is because I gained a lot of experience with the robot. My understanding of the anatomy of the head of the pancreas is better than 10 years ago. My anastomosis between the pancreas and the jejunum, I think, is better than 10 years ago. This case not only need to remove the head of the pancreas, the goal to preserve the duodenum, preserve the bile duct, and you only need to do one anastomosis, which is pancreaticojejunostomy between a normal pancreas and jejunum. So 10 years ago, I was focusing on how do I finish the surgery, how do I reduce my complication of pancreatic leak. 10 years later, I'm focusing on how do I preserve more normal organs, because I'm not worried about, my anastomosis. I'm not worried about, how do I finish the surgery, right? So you can see, even using my personal experience, this is reflecting a learning curve of my robotic approach. And the only reason I can do this is because all the teamwork I built up, in the last 10 years in the high volume center. Again, here you can see ICG really can demonstrate the anatomy of the bile duct, make the surgery a little bit easier. harmonic device is much better than vessel sealer. I just don't think you can use a vessel sealer to do this kind of dissection. It's just so bulky. It's good for obese patient to control the fatty mesentery, but for any fine dissection, the vessel sealer just cannot give you this capability. Here, I transect the pancreatic duct and make sure I check the margin. There's no high-grade dysplasia. And the last portion of this dissection is just to get this off the common bile duct. I'm going to move the video a little bit more. So here you can see the final view of this dissection, that the common bile duct was preserved, and all the intrapancreatic vasculature was nicely demonstrated. And the vessel can also be confirmed with ICG to make sure they have good flow in it. Obviously, patient was recovering well after the case. Now, this is a summary of my program in the last 8 years, starting from 2015 to 2023. 2023 was the first year in my program, the robotic volume is higher than the open pancreatic volume. And I look at my own outcome, and especially the first 300 XI robotic Whipple, the pancreatic fissure rate, delayed gastric emptying 5%, wound infection 2%, mortality rate is less than 1%. So I remember when I had my first mortality after robotic Whipple many years ago, Dr. Cameron told me that if you don't control your mortality rate, you're not going to justify using robot. So again, you have to constantly evaluate your outcome to make sure you're on par with all the published data, with your own group, with all the other high volume surgeons. Keep learning, keep improving, and this is the only way to build a program successfully. I have 3 other partners also doing robotic pancreas surgery, and many of my graduating fellows, they are also doing robotic Whipple in their own institution. This is just not a one person's endeavor. This is always a group effort. So just putting a summary, you gotta do this based on clinical evidence. You gotta do this in a high volume center. You just cannot do it if your program only do like 50 Whipples per year. The volume is important, especially for the beginning. When I started, my program had, I think in 2015, we have 9 surgeons doing pancreas surgery. We do about 350 Whipples per year. But now my program has 5 surgeons. We still maintain over 200 Whipples per year, and more than half was done using a robotic approach. Right, the volume is the key to make sure every day, every week, you have a few robotic Whipples happening. The outcome is critical. You have to constantly look at your own outcome and keep improving. So I'm going to stop here. Thank you for your attention. Thank you for this opportunity to share my experience with this elite group. I see many friends here, many colleagues here, and happy to address any question. Thank you.
Thank you for your nice and very impressive presentation. And is there any comment or question in the floor, or you can write the message to me, and then I will ask the Professor Jin-Hee. And I have a question for your presentation. First, What are your thoughts on case selection for robotic PD? Do you think you can perform all PD with robotic, or sometimes you choose open PD?
Yeah, the case selection, as I touched a bit earlier, I would say nowadays, if any patient need a major vascular reconstruction, I'm not going to do it on the robot because I just think even with 10 years experience, I'm still not comfortable to do a better job compared to my open Whipple. So all those cases, I'm still doing those cases, open. Especially for those cases, if I may need a graft, that I just don't think I've gained enough experience to do this better on the robot. Other than that, whenever possible, I put patient on the robot because again, it's becoming sort of addictive that every time I do an open case after I remove the tumor, when I start doing all this reconstruction, and I wish I can dock my robot arm because I can see better, right? Once you start doing robotic surgery, the magnification cannot be replaced. You do open surgery, you can wear your loops that gave you a little bit magnification, but this is not comparable with a robotic 20 times magnification. The bottom line is, to me, I think this is a moving target. Every year, your case selection criteria probably will change. Depends on your experience, depends on your learning curve. Again, I've seen many robotic vessel reconstruction. I've seen robotic aorta reconstruction. But you have to ask yourself, doing this robotic surgery, is this going to help your patient? Are you comfortable like your robotic approach is better than your open approach? If the answer is yes, sure, go for it. If you don't think your skill set is ready, well, patient is always the priority. You're not going to try to do the robot for the sake of robot.
Thank you for your nice answer.
Professor Jin, I'm Chang from Yonsei. Thank you very much for your wonderful video and great outcome. Congratulations. So I think that performing nowadays the minimal invasive Whipple procedure, laparoscope or robotic pancreaticojejunostomy is very increasing these days. So surgical education is very important, no doubt about that. During your presentation, you commonly commented your program for a robotic pancreatectomy. So could you be more specific on that? I think in my mind, the surgical observation, video library, and in vitro simulation in the reconstruction phase is okay, but more importantly, resection phase training, how could you manage it for your junior surgeons?
Yeah. Good to see you, Professor Kang. As you can understand, in the United States, we have residency, we have fellowship, and once you're done with fellowship, you're on your own. So if you don't think your robotic pancreas experience is good enough, then this is getting to the next level of learning, the so-called CME, learn from the other surgeons' observation of video. And I showed you one of my slides. 3 of my partners start doing robotic Whipple on their own, in the beginning, they always come to my OR to watch. But they cannot scrub into my cases because the system is set up that only one attending can do the case. But again, if you are in a program doing hundreds of pancreas surgery per year, and then you can select appropriate patient to start, right? So I remember when I started, I probably the first year I only do like one robotic Whipple per month, and over the years I probably can do one per day. It just needs a volume to keep practicing, repeating. Now, teaching my partner to do robotic Whipple is very different than teaching my resident to do robotic Whipple. First of all, you don't need to teach every single resident to do robotic Whipple at all because they may have completely different career paths. They may not be a pancreas surgeon when they graduate. And we don't need to train like hundreds of pancreas surgeons in the United States, right? So that's why we have the fellowship. The fellowship is a very different. All those HB fellow, so we have one HB fellow per year, one per year. Just think about it, that, we do hundreds of pancreas surgery per year. We only have one HB fellow per year. How much exposure he or she will get during this 2 years training, whether it's open or, robotic approach, right? So again, if this trainee spends enough time on the simulator, in the dry lab, I'm sure, as I showed you in my slides, when they graduate, they're going to take this approach to their own patients. I guess the answer, the easy answer is the learning and training never stop. Every year, I think I'm a little bit better than last year. I still keep learning new things by watching videos, maybe watching your videos. Every time I, attend a meeting in Korea, I learn some new tricks. So don't ever be convinced that you can be a master within 2 years or 5 years. That's impossible. The learning should never stop. The learning curve is a misnomer because it depends on what case you do. If every patient is the same, I'm sure you're going to draw a beautiful learning curve. The reality is every patient is not the same, right? Before I miss the first, right posterior hepatic duct, I thought my HJ was perfect. I never had any HJ leak until that case happened. And I realized if I don't use ICG, how can I be sure that, my anastomosis is okay? And how can I be sure I don't miss any, small duct somewhere else, right? So again, training, learning, they all have different levels. They should never stop.
Thank you for your nice answer. It's very wonderful presentation. And because of the time limitation, this session will be closed. And Professor, please, moderator.
Yes. Thank you very much, Professor Jin-Hee, for outstanding lecture. So to conclude, I would like to invite Professor Kang, President of K-MIPS again, and for his closing remarks. Professor Kang?
Yes, thank you. This is what K-MIPS prepared for you today. I really enjoyed the symposium. Did you enjoy it too? I know there are so many parties to celebrate the end of the year. The Professor Yoo-Seok has gone. Professor Naka has gone. But you are here to study minimal invasive pancreas surgery with us. Thank you again for staying with us at the end of this webinar symposium. I really appreciate all honorable speakers, commentators, and the moderators. In addition, I also appreciate my colleagues, Wooil, Eugene Che from K-MIPS International Committee for preparing for this all arrangement. Good night, Merry Christmas in advance, and Happy New Year in advance. Bye-bye.